very much, Leah, for the introduction, and thank you everyone for coming on tonight for our talk about spirometry and asthma. As Leah said, this is the second of our series of online talks that we've done that sort of started last year, during COVID, and it's been a tough year. And we're not out of it yet. And we thought, from a practice point of view, what could we do to give back and to provide a bit more value for our local GPs, both in Melbourne and also in Gippsland, because we really appreciate the support that we get from all of you. So we really hope that this talk is going to be helpful, and it's purely for you guys. So please, as Leah said, put questions in the chat. We can discuss anything, any case studies or anything which would be good. So I'm going to start by sharing my screen again. I will try and bring up some slides. While that's coming up, I know some people here tonight, actually, there are a couple of GP practices that are using this as a part of their GP education program, which is really exciting. So thank you very much for including this in your practice. Certainly, if anybody else is out there that would like to include this, we're going to continue to do these talks. So if you want to include it into your general practice education, that would be fantastic. So this is what we're talking about, spirometry and asthma. So to start with, I thought I should let you know that we've got our lung function lab at Bentley Specialist Centre now. It's up and running. There's a referral form that you can download if you like. I might actually ask Leah if you're able to just put that link into the chat there. You can copy it, and that'll download the PDF of our referral form. Lung function's all bulk billed, so if you wanted to send any patients along for lung function, we can organise that for them. And there we are in our respiratory lab. I also want to take this opportunity to introduce Sheetal, who's a new respiratory physician joining our group about in the next month or so. And we're lucky enough actually to have Sheetal on the line here tonight. So Sheetal's joined us, which is excellent. And we're looking forward to having her work alongside us. And I'm also looking forward to having her here tonight to be able to help me answer some of these questions and go through some of these case studies together. Cabrini's actually opened up consulting rooms in Hawthorn, and so she was also going to be consulting from Hawthorn. So anyone who has patients around that area, that might be quite convenient too. And also he's going to join me down in Wonthaggi at Bass Coast Specialists. And she's joining our team, which includes Sean and Tim, who have been with us for a little while now, and between us cover a few different locations there. Just want to remind everyone about my YouTube channel. I'm very excited. I've got about 380 subscribers now. And my most recent videos is just a series about spirometry. So if there's anything else that you want to learn about spirometry, I've done just a short series of videos there, which you can certainly have a look at, where I go into detail about some aspects with regards to spirometry. So what we're going to do tonight is start by explaining about spirometry and a bit about the physiology. Talk about the interpretation of spirometry tests, and really try and tailor it into the management of asthma, and explain how the use of spirometry can really help the management of asthma. And we use some case studies to do that. And as I said, we'll have lots of time, hopefully, for questions and discussing the cases. I quite like this quote. It's funny, but you never really think much about breathing until it's all you think about. And this really encaptures why I like respiratory medicine, because breathlessness is really significantly perceived by patients, and if people have a problem with their breathing, it affects their quality of life, really significantly. And so, what I love about respiratory medicine is that if we're able to improve people's breathings, we can make a really big difference to the way they feel. And that sort of comes really into what our mission is at Lung and Sleep, which is to inspire and help as many people as possible improve their health while paying specialist attention to the treatment of their lung and sleep disorders. And I love it because it has massive impact on people's quality of life. So everybody knows what lung function testing is in spirometry. And so I just wanted to start off by just talking about the main values that we see when we get a lung function report sent back to us. And one of the difficulties in interpreting spirometry is that there are too many numbers on the page. And so when you're faced with a test, when there are too many numbers on the page and you're not looking at them all the time, it's confusing. And so to simplify it, I think what we really need to be doing is to be looking at just a couple of those values. And so the first one is the FEV1. And the FEV1 is the forced expiratory volume in 1 second. And the FVC is the forced vital capacity. And so what happens during a lung function test is the patient takes a full breath in, breathes all the way in until they can't get any more air into their lung. And then they forcefully exhale as hard and as fast as possible until they can't get any more air out of their lung. And we measure those volumes. And the amount of air that they can expel in the first second is the FEV1. And the total amount of air that they can expire is the forced vital capacity. So the forced vital capacity gives us a bit of an idea about total lung volume. And it is the total lung volume, except for the amount of air that stays in the lung at full expiration. And so we need some air in our lung at the end of expiration, otherwise the lung will collapse. So there's always going to be some air left in there. So the forced vital capacity gives us a bit of an idea about lung volume. The next important rate is the ratio between the FEV1 and the forced vital capacity. And that ratio is sometimes called the forced expiratory ratio. And there's a typo on that slide I've just realised, just there, that should be the forced vital capacity, FVC, not FVR. Anyway, the ratio of these two is really important because it tells us whether there's airflow obstruction. And so what it means is that the forced vital capacity, the FER should be 70%. If the FER is 70%, what that means is that when we forcefully exhale, we get 75% of the air out in the first second, and then the rest just comes out over the next 5 or 6 seconds. So we breathe all the way in, we force it out, 70% comes out in the first second, and then the last 30% just tails out over another 5 or 6 seconds. If you can't get 70% out in the first second, then there's something obstructing expiratory airflow, something slowing it down. And so that is what airflow obstruction is. So airflow obstruction is something slowing down the speed by which you can forcefully expire air out of the lung. And we get that from that FER ratio. The rest of the numbers on that page under spirometry can pretty much be ignored, especially things like the PEF, which is the peak expiratory flow, or the FEF, 25 to 75%. I think that we can completely ignore those. So when we're looking at interpreting these tests, we look at the FER. That tells us, is this patient obstructed or not? The next thing we look at is the forced vital capacity, because the forced vital capacity tells us whether there's airflow restriction. Airflow restriction essentially just means small lungs. So if the lungs are small, then there's ventilatory restriction. Can't get as much air in, lungs are restricted. If I put a belt around someone's chest, they'll have ventilatory restriction. Or if I do an operation to remove one lung, they'll have airflow restriction because their lung volume is reduced. Or if they have pulmonary fibrosis and their lungs are scarred, their lung volume is reduced, they'll have ventilatory restriction. So then the FEV1 on its own as a value only tells us about the severity of airflow obstruction. And that's where I think sometimes people get confused because they look at the FEV1 first, and without looking at the ratio, it's hard to interpret the FEV1. We then calculate those values for the person and we compare them to the normal population, and the normal population normal values are based on their age, sex, height, and nationality. And we can present those numbers either as compared to a lower limit of normal. So say an FEV1 should be greater than, say, 2 litres for a certain person, or we can express it as a percentage of predicted. And it's quite frequently presented that way, where greater than 80% for FEV1 and FVC is considered normal. And as I said, the ratio of the FEV1 to FVC being probably the most important number has to be greater than 70%. If it's less than 70%, there's airflow obstruction. We can then do the same test after a bronchodilator. So we give, say, 6 puffs of Ventolin through a MDI and spacer, and then we do the same test again. And if the patient's values improve by 12% and 200 mils, and that can be either in the FEV1 or the forced vital capacity, then that is a significant bronchodilator response. And one thing to remember is that a significant bronchodilator response means that there's quite a large bronchodilator response. That means lung function has improved a significant amount. It doesn't mean that the patient's going to get better with bronchodilators. It actually means that the patient's probably got reactive airways and is more likely to have asthma. So a significant bronchodilator response is sort of suggestive of asthma. It's not really a test to determine will this patient feel better or should this patient be treated with bronchodilators. Because one of the things I always had difficulty getting my head around is, well, by definition, COPD is fixed airflow obstruction. So they don't get better with a bronchodilator. They don't have a bronchodilator response. But as we'll get to later, the first line treatment for COPD is bronchodilation. So why is that? And the reason for that is that when we talk about a significant bronchodilator response, it's a large response. It suggests reactive airways. It doesn't mean that the patient will or will not get symptomatic benefit from bronchodilation. So we should have a look at some tests. And so here's a lung function test just to orientate ourselves. As you can see, there are way too many numbers on the page. They're all in the wrong order, but that's how the machine spits them out. So this is one from our lab in Bentley Specialist Centre. And so what we want to do is we want to sift through and find the most important number on the page, which is the FEV1 to FVC ratio. Can someone find it? And can someone put in the chat what the FEV1 to FVC ratio is? Let's see if we can all make sure that we can use the chat function okay. And I'm going to get the chat down here so I can see your answers. So what's the FEV1 to FVC ratio for this person? $84, we've got it, Ron. $84. So if we look at those columns of numbers, we've got the pre-baseline. So that means the pre-bronchodilator, this is the baseline result. The LLN is the lower limit for normal. The Z pre is trying to calculate the statistical difference from the norm. And the thing I like, I don't look at those numbers because I don't quite understand them, but what I do like about that column is that when they're all green, we know that they're within the normal limits. When they're red, it's abnormal. So when you have a quick visual of the results, if everything's in the green, you can probably assume that everything's normal. So the ratio is 84, or 84% or 0.84. So what that means is this person does not have airflow obstruction. The next value we look at is the forced vital capacity. And as a percentage of predicted is 93%. So we know greater than 80% is normal. So this patient does not have airflow restriction. So by definition, just looking at those two values, we know this person has normal spirometry. In the second column there, just there is the post-bronchodilator. So we've got post-bronchodilator values, the percentage of predicted, the amount of change, and then the percentage change. And we said that a significant bronchodilator response needed to be 12% and more than 200 mils. Here, they've made the 200 mils, but it's only 5% because they've started off with good lung volumes. And so this is not a significant bronchodilator response.
Can you just explain again what the Z pre was on that last slide?
Probably not, because I don't really understand it. So the Z pre is Sheetal might be able to help. It's a statistical calculation about how far off the pre-baseline is from the expected value. As a value, I don't find it all that useful, but I find the fact that they colour it very useful.
Yeah, I'd agree with that, Barton. It's not really relevant to your clinical interpretation. It's more how far off normal the value is. And because it's green, it's still within the normal range.
Yeah. Gas transfer is a useful measure. Gas transfer strictly is not a part of spirometry, but it's part of lung function that we usually do when we do spirometry. Gas transfer is sometimes said as the DLCO or the TLCO. The way it's measured is we get the patient to breathe in a known concentration of carbon monoxide, and we know that carbon monoxide readily is transferred across from the alveolar space into the red blood cell and in the blood vessel. And so what we're trying to do is to determine how well the lungs take carbon monoxide from the air that's breathed in and get it into the blood. And it's a good marker of how well the patient is going to get oxygen from the air and get that oxygen across the lung tissue into the blood. So what it's measuring is the actual lung tissue. It's measuring the alveolar capillary membrane. And so disease of that membrane will cause a reduction in gas transfer. And really there's sort of 4 main causes for reduction in gas transfer. There's either a disease of the pulmonary parenchyma, such as pulmonary fibrosis or emphysema, or there's a disease of the pulmonary vasculature, and it's either going to be pulmonary hypertension or pulmonary embolus. So we noticed that asthma is not on the list. And the reason asthma is not on the list is asthma is a disease of the airways, not of the actual alveoli, not of the lung tissue itself. So here's another, the same lung function test as we were looking at before, but I've just uncovered the gas transfer. And so the gas transfer here is the DLCO, and we can see that that is 111%, so slightly better than what we would expect for that person, so that's certainly normal. So this person has normal gas transfer. Okay, so does anyone have any questions about that before we crack on to have a look at some cases?
We do, Barton. Lisa was just asking, why do you look at the zero, when you look at the lung function, when you're looking at the pre-level, why do you look at the 0.84?
It's a good question. So we're looking, so in that's the only case that we don't look at the percentage of predicted, because we're really looking at the ratio. And so let's just go back quickly to it. By definition, we say that less than 70% in that ratio is abnormal, so we should look at the absolute ratio. Having said that, and I think that that's probably the most simple way to look at it. It can get a little more complicated though, because as we age in elderly people, it's normal to develop some degree of airflow obstruction. And so in an elderly person, their ratio may at 65% or so, or may be normal. And so you're quite right in pointing out that, you know, maybe we should take the percentage of predicted into account, and that might take into account the differences with age. However, I think for simplistic sake, and the way I do it is I just look at that 70%, you're obstructed. If it's less than 70%, you're obstructed. If it's not, you're not obstructed. And I think that just keeps it a little bit simpler.
Barton, what is the lower normal for gas transfer? Is it 80%?
80%, yes. Yeah, so it's easy to remember, 80% for everything except the ratio. The ratio is 70. And cardiac failure you're absolutely correct, Charmaine, that cardiac failure can cause a reduction in gas transfer. So essentially anything in the alveolar space can cause a reduction in gas transfer. Yep. And differentiating heart and lung causes of breathlessness is a good one. It's a little bit hard with the gas transfer. And I guess that certainly lung function can certainly help differentiate the differences between heart and lung causes for breathlessness. However, the gas transfer itself on its own isn't really going to be the thing that's going to differentiate the two, because there are certainly other causes for that. And usually if the gas transfer is reduced, we look for some sort of cardiac cause, some sort of lung cause for that. But certainly one of the causes for pulmonary hypertension is obviously heart failure as well. So that can contribute to that. Okay, so this first case is a 28-year-old lady who says that she had childhood asthma, takes serotype once a day, sometimes gets a hoarse voice, has been unwell now for about 8 weeks after an upper respiratory tract infection, and most of the symptoms have got better, but the cough has persisted, which is quite a common situation that we're faced with. So what's the first thing that we should do for this girl, this lady? COVID test. Yeah, I think she's had a cough for 8 weeks. Maybe, hopefully she's had a COVID test. Maybe not. But yeah, probably in this current situation, we would make sure that she doesn't have COVID. So she doesn't have COVID.
Lisa has suggested a lung function, some spirometry.
Yeah, excellent. So we should do lung function. And so does somebody want to have a look at this lung function test and tell us what's going on? Or what's the FEV1 to FVC ratio? What's the diagnosis? Because I think when someone presents like this, the first thing we need to question is, well, you've told me you've got childhood asthma, but we can't just assume that you do have asthma. A lot of people are told they've got asthma. They might have been told they've got asthma by their friends or their teacher or someone else, and they might not have been formally diagnosed. So there's an obstructive picture, examine them. Yep, it's a good idea. Look for Louise. 65, yes, the ratio is 65. And so here we've got lung function presented in a slightly different way from a different lab. And so the numbers are in a completely different order. But once again, we do have the pre and the post. And the pre FEV1 to FVC ratio expressed as a percentage is 68%. And so that means that this girl does have airflow obstruction. Now that we know there's airflow obstruction, looking at the FEV1 as a percentage of predicted is useful because that tells us how bad the airflow obstruction is. And so 74% is mild airflow obstruction because we know that 80% is normal. The forced vital capacity is 83%, so there's no ventilatory restriction. What about the bronchodilator response? So we've got airflow obstruction, FEV1 is 74%. And now we've got a %19 improvement after bronchodilator and FEV1. So this is a large bronchodilator response. This is a significant response. If we look at the absolute values, we've got a FEV1 in litres from 2.79 litres up to 3.3 litres. So this is a 500 mil improvement. This is a big bronchodilator response.
But would we be right in suggesting that depending on the lab, the numbers can be in all sorts of different orders or presentations?
Yeah, exactly. And it's very annoying, really, that they do it like this. And this is, I think, what makes it really difficult to interpret. That there are too many numbers on the page. They're all in a different order. Depending on where the test comes from, they will come in a different order. And so I think that the key is to remember what are the important numbers. There's only a couple of them. And then just go through the same system every time when looking at the results. And so even if you just look at one number on the whole page, you can tell if they're obstructed or not. So if you've got someone with breathlessness, wheeze, asthma, COPD, there's really only one number you need to look at, and that's the ratio, and you can tell whether they're obstructed or not. And the lung volume do confirm obstruction. I don't think you can see my mouse, but the flow volume loop there has that typical sort of scalloped shape to it. Like that. And you can see that in the dotted line is the post-bronchodilator, so there's a significant response. So that's really useful because now we know that this girl has asthma. The other thing we know is that this girl's asthma is suboptimally controlled, not just based on the fact that she's got cough, but on the fact that she's got a significant bronchodilator response. And if you think about a significant bronchodilator response, what that means is that if the lung function was able to improve by that much after a Ventolin, before the Ventolin, the airways were all narrowed. So if there's a significant bronchodilator response, it's abnormal. So we know that this person's asthma is suboptimally controlled. So if we improve her asthma control, hopefully what we would do is improve her lung function to normal. And we can see that the post-bronchodilator lung function is normal. So what we want to get her to the point is we want her pre-bronchodilator lung function, spirometry, to be as good as or better than what her current post-bronchodilator spirometry is. And then when we give her the bronchodilator, we do not want to see a significant response, because if the airways are open and they're not inflamed, so if the airway wall is inflamed and narrowed, it's abnormal. If the airway wall is not inflamed and it's open and relaxed, then Ventolin should not lead to a significant response, because the airway is already open. So what should we do for this girl? Let's have a go at what they would do. Maybe if people put into the chat what they think that they would do with this. Sheeta, why don't you tell us how you'd approach this girl while we get some suggestions in the chat?
Yep.
Right, she was on Seretide and she said she used it once a day. But the other Sorry, Sheetal, continue.
No, you're right. So it sounded like she had some post-viral symptoms and obviously has evidence of hyperresponsiveness on her lung function, so active asthma. I think some of the input from the group is checking her inhaler technique, which would definitely be the number one thing to do, making sure that she's using her inhaler correctly, that she's using it with a spacer if she's got a MDI inhaler. But also she mentioned hoarseness of voice, so making sure that she's rinsing her mouth out after using inhaled corticosteroids and there's no evidence of thrush, I think would be important. And then considering whether, if she is using her inhaler appropriately and technique is good, then consider increasing her serotype to help improve her symptoms. I don't think that, given her mildish symptoms, I would be considering oral prednisolone at this stage, but it would be something to keep in the back of your mind depending on how she responds to an up titration of her doses.
Yeah, exactly. I think that the point of the hoarse voice is really significant and certainly suggests that maybe she's not taking it, and she's said she's only taking it once a day, so I suspect that compliance is probably going to be an issue. I agree. I think it's probably the most common cause for suboptimal asthma treatment, asthma control is probably compliance or using the treatment. But I think it's useful to think about what we're trying to achieve. And what we want to achieve is two things. We want to achieve control of symptoms. So people with asthma should be able to live a normal life free of symptoms. They should not have symptoms of wheeze, chest tightness, or cough at night time. They should have normal lung function, as I explained before, and they should be able to participate in their work and exercise without limitation from their asthma. And we also want to reduce future risk, because if we allow an asthmatic to have inflamed airways, then they're at risk of exacerbation. So a virus comes along, and if the airways are not inflamed, they're less likely to exacerbate. But if there's airway inflammation, they're more likely to exacerbate when exposed to a virus or a pollen or a smoke or whatever else it might be. We also want to make sure that the airways are not inflamed, because if airways are inflamed for a long period of time, it can cause some permanent lung damage and loss of lung function. So you can get that chronic asthmatic with fixed airflow obstruction. And we want to try and do all that with a minimal amount of medication, because we want to reduce side effects from the medication.
Barton, we've just got a comment around, does the patient need to stop the preventer before? And there's just a comment around Singulair. Do you have any thoughts around those?
Does the patient need to stop the preventer before lung function, do you mean? So what we normally do is we tell patients not to take their medications on the day of the test. So they don't need to stop it before the test, just on the day of the test. And it's really just to see, is there a significant bronchodilator response? Singulair, I haven't really put Singulair into this talk, but I might come back to that question later on, because we get to a point where we're talking about sort of add-on therapies. So could you just remind me to come back to the Singulair? So I think, yeah, exactly as Sheetal said, but what we want to do is make sure this girl's actually taking the serotype, that she's taking it with the appropriate technique. I don't think prednisolone is necessary in this person, because their symptoms are relatively mild. They're not having a significant exacerbation. I think we should try and avoid prednisolone if it's not necessary. And then I think we need to follow her up. And what we want to do is we want to follow her up in a couple, at least in initially we want to follow her up early to make sure that she's improving, but we should probably also repeat lung function in 2 or 3 months. And so 2 or 3 months is usually long enough to be with good compliance on inhaled corticosteroid to normalize lung function. And so at that time, I'd like to see her lung function normal. And so if we look at obstructive lung disease, we can sort of break the management of obstructive lung disease into asthma and COPD being the main obstructive lung diseases. And one of the reasons I started to do respiratory medicine is because it was so easy. Like, I couldn't understand rheumatology with all those antibodies and endocrinology with all those hormones. It was all way too complicated for me. And respiratory is fantastic, because all we really did is have patients with obstructive lung disease. We gave them Ventolin. If they needed more than that, we put them on Seretide. And then things got a little bit more complicated when we had Spiriva, and we realized that people with COPD could also have Spiriva, and that was great. And that was basically it. However, things have become more complicated now with the addition of tons more inhalers. And the good thing about this is it gives us a lot more to choose from. But the bad thing about this is it can make it complicated. And so I've put together this slide to try and sort of conceptualize where they all fit into. I'll send this out to everyone. So I'll give you a copy of this as I'll send out all of my slides if you're interested. But just to take you through this, so we'll start with COPD. COPD, what we want to do is we want to treat patients for their symptoms. And so the first thing we want to do is treat with bronchodilation. And we can either start with the LAMA, which is a long-acting muscarinic antagonist, or we can start with the LABA, which is a long-acting beta agonist. And they both essentially do the same thing, but they work through a different pathway to achieve relaxation of smooth muscle and bronchodilation for the symptomatic relief of breathlessness. If one of them is not enough, we just add in another one. And so that we've got combinations of the LABA-LAMA, and you can use any combination you like. In patients with COPD, really the only role for inhaled steroids is if they've got severe airflow obstruction, so an FEV1 less than 50%, and also if they've had frequent exacerbations. So if they have exacerbations, they do get benefit from inhaled steroid. And the other situation is if they also have a component of asthma. So if they have a component of asthma, we need to treat both, and we treat the asthma side of things with the inhaled steroid. If we look at the asthma pathway, the first line treatment is inhaled steroid. And inhaled steroid is the most important part of treatment because it settles down that airway inflammation. It actually treats the asthma. But bronchodilators don't treat the asthma. All they do is open up the airways. So inhaled steroid is most important. And we can start with inhaled steroid by itself if you want to, or you could start with a combination inhaled steroid with a long-acting beta agonist. And there are different combinations that you can use. We start low. If that's not enough, we gradually increase the dose until we get good control of symptoms. And then once we get good control of symptoms, we can also back titrate. So we can reduce the dose to try and achieve those things that I explained before. Normal lung function, no symptoms, well-controlled asthma with the lowest amount of medication. If patients are still symptomatic on the high dose of inhaled steroid and the beta agonist, that's when the next step is to add in the Spiriva. And so we can add in Spiriva to the treatment of asthma. If patients are still symptomatic at that point, that's when we can start thinking about add-on therapies. Let's go on to another case. This is a 78-year-old lady.
But can I get back to that slide just for a moment while we're there? There's a question, why are there more LAMA options available than LABA options?
Good question. Got no idea. Sheetal?
I think there's more that, I think this is just a good summary. I mean, there's so many inhalers out there now. There is more than just on Breeze as a single dose LABA.
The other one, they've got Oxys, but you sort of don't see Oxys all that often, and it's a twice daily, so it's not used quite as often. But On Breeze is the only long-acting beta agonist that's an inhaler by itself, which is a once daily. Why that is and why other companies haven't come up with other ones, I don't know.
And often we don't use single dose LABA alone because in asthma, as Barton will go through, you'll start with an ICS and then add on a LABA. And often with COPD, we tend to use a single dose LAMA first rather than a single dose LABA.
Yeah, that's certainly what I would do as well. I think that's probably what most people do. And the reason for that might be is that Spiriva was the first and we're used to that. So we tend to go with the LAMA first.
Yeah. There's a few other questions as well. Sorry, Leah, you go ahead.
There's a question around back to admitting the morning dose before spirometry, and how does that tell you the efficacy of the preventer if they did not take their morning dose?
That's a really good question. The tradition has always been to not use the inhalers on the day of the test, and the main reason is to determine if there will be a significant bronchodilator response, and that is from a diagnostic point of view. So if you have someone presents with symptoms like that first girl in the case did, we want to know, does she have a bronchodilator response, because that helps to confirm the diagnosis of asthma. If they take their inhalers on the day, then they've had bronchodilator already, and so giving them the Ventolin might not achieve bronchodilation, so you might miss a significant bronchodilator response. However, when we treat that girl and she's improved and she's feeling better, and 2 months later she's on her treatment and we now want to make sure that her lung function is normal, it would make sense to do her lung function on that day with her medication. I think that traditionally we normally don't do that. So the routine is just to tell them not to. I suspect that it doesn't make that much difference once we're looking to see if there's been improvement, because if they've been on inhaled steroid and there's no airway inflammation, missing their dose just for that morning is not going to suddenly create a bronchodilator response or affect their lung function. So I think from simplicity and in terms of like booking the test, we tend just to say not to take it. But you make a really good point. When we're doing the test to determine treatment effect, they probably should have the treatment because that's what we're testing.
With this lady, would you expect to hear a wheeze on examination? And would you then not need a lung function test?
You may. So you may hear a wheeze, and certainly if you heard a wheeze, and that would be helpful in your assessment, and that would certainly add a lot of weight to the possibility that this is asthma. But a lot of these patients actually don't have wheeze, especially when their symptoms are cough. If they did have a wheeze, do you need lung function still? Well, I think that that's probably enough clinical information to go on and to start treatment, and you'd treat probably exactly the same down the same lines. My feeling, and maybe I'm biased because this is what I do all the time, but I think we should still do lung function in that situation though. It shouldn't hold up treatment, but we should do it, because what we want to do is we want to document that this is definitely asthma. We want to see how badly affected the lung function is, and we want something to compare back to. And so when we do the lung function again, we want the lung function to be normal. If we just purely relied on tally on a O'Connor, the good clinical medicine, if we see this person in a week or so, we'd expect the wheeze to have gone. And if the wheeze has gone, then that certainly suggests that there's been improvement, but it doesn't mean the lung function is going to be normal. And I think in these people with asthma, we want to make sure their lung function is normal. So absence of wheeze, I don't think we can then assume means that the lung function is normal.
Are muscarinic receptors more responsive
than the adrenergic? And I'm not sure. Not that I know of, but detailed pharmacology.
So, I don't think that the receptors are any more responsive. I think the evidence for benefit in COPD has been quite strong for LAMAs, so that's often why we prescribe them first.
Not always is asthma. That is definitely true.
That's the point. I think it's important to get a baseline. When someone first presents with wheeze or symptoms suggestive of asthma, I think it's important to get a baseline lung function. So as like Barton said, you have something to compare to post-treatment and to confirm the diagnosis.
So should we get on? So this is a 78-year-old now with cough and shortness of breath on exertion. Reports having episodes of bronchitis in the past, maybe once a year. He's also an ex-smoker now and quit 15 years ago. And he's also on Steroids, says that they take it twice a day. So what do people think about this? In the chat, maybe put down anything you like. If you can find the FEV1 to Fcc ratio, if you can tell whether they're obstructed or restricted, is there a response? What's the gas transfer? What's the diagnosis? What are you going to do?
We've got some quiet in the chat.
Yep, we've got it though. We've got the ratio, so it's obstructed exactly. Because once again, this is another lab, another order, another way of doing things. Curve looks obstructed. Yes, I agree. The curve does look obstructed. Yep. Reversal obstruction. Yep. The FEV1's 59%, so this person's a bit more obstructed than the previous one. The significant response of 19%. So once again, we've got a big response. There's a significant response in the values of FEV1 from 1.18 litres up to 1.4 litres. The forced vital capacity is 78%, so that's slightly low, but notice after bronchodilator, it's 86%. So that means that once you open up the lungs, the lung volume is actually normal. So this person does not have actual ventilatory restriction. They're purely obstructed. And exactly a low DLCO. And so that's really significant. So what does that mean? What does that mean about this person that's different to the last person? means that this person not only has disease of their airways, but also has impaired gas exchange, could have heart failure, have alveolar disease, lung tissue disease. Exactly. So this person's got parenchymal or pulmonary vascular disease. And so what's that going to be due to? Most on the balance of emphysema. Exactly. It's going to be due to emphysema because we know that this person's been a smoker. And so what does this person have? Do they have asthma, or do they have COPD, or do they have both? Both, exactly. So this is a combination of COPD and asthma. And so how are we going to manage this? Well, we're going to manage both. Do we need antibiotics? Does this person need antibiotics? No, good. Sheetal, does this person need antibiotics, do you reckon?
Sorry, did she have a productive cough?
Nope.
No. Then no. Depends if she has infective symptoms.
Yeah, I agree. I think that if there's infective symptoms, antibiotic is useful, but if in the absence of significant infective symptoms like sputum production, I don't think that they need antibiotic.
Yeah.
Do they need prednisolone? Probably haven't given quite enough information. And once again, it's probably based on the clinical findings and how distressed they are by breathlessness. So prednisolone is going to treat the airway inflammation. If there's a lot of airway inflammation and they're quite breathless and you're concerned about them, then certainly some prednisolone would be beneficial. What do we do about the inhaler therapy? They're on Seretide, add Spiriva, check they're taking it. I guess we're going to do pretty much similar to before. And once again, we're going to follow them up. That's a good question about the DLCO and the asthmatic. So in patients with chronic asthma who act more like a COPD because they've got fixed airflow obstruction, they actually usually still have normal gas transfer because asthma is caused airway disease, but not parenchymal disease. So in these chronic asthmatics, they can be really severely affected. They can have really severe airflow obstruction, but their gas transfer should be normal. Next one is a 34-year-old lady with cough and shortness of breath, and this has been going on for 2 or 3 years. Seems to be episodic, worse on exertion, but also associated with tightness. She describes as tightness across the chest. It can also occur at rest when quiet at night. It's interesting. It does have a history of hay fever. And so, what do we think about this lung function? This is back in our lab, so it's got the nice color clues. Is there any risk, while you're answering that question, I'll just have a look at here. Is there any risk of the steroids introduced early in COPD? I don't think so. I think that if you were going to treat this person with prednisolone, that would be completely reasonable, but you do it for a short course. And a short course, there's no definition as to how long we should treat with steroids is really until they show symptomatic benefit and start to improve. And so you could certainly give that person steroids, but you certainly wouldn't want them to be on oral steroids in the long term. Normal, exactly. Inhaled steroids. So yes, that person should definitely be on inhaled steroids because they've got an asthma component because of the significant bronchodilator response. So yes, this is normal. You can tell it's normal because it's all in the green. Oops. But if we go through it, we can, I haven't marked them out. The ratio is normal, 81%, 80.81. The forced vital capacity is normal. There's no bronchodilator response and gas transfer is normal. So here's this person presenting with symptoms that could potentially be asthma, but normal lung function. So what are we going to do about this? And I think the first thing to do is think, okay, well, is it really asthma? Does this person have asthma? Do you think that this person definitely does or definitely does not or not sure? Reflux, could be a cardiac cause. So absolutely, we need to think, could this be something else? Heart failure, yep. Unsure, I'm unsure too, I don't know. These are the difficult ones. When they've got abnormal lung function, you've got something to treat, it makes it a lot easier. PEs, exactly, it could be something like, it could be having PEs. So we think about the symptoms, but the symptoms don't necessarily mean asthma. So what other differentials could we consider? So wheeze could be caused by vocal cord dysfunction, which I'm going to talk a little bit about. It could be caused by excessive dynamic airway collapse. What that means is that our central airways, like our trachea and our main bronchi, are held open by cartilage. And when we breathe in, our airways open up, and when we breathe out, they close just a little bit. Sometimes they close excessively. Sometimes they close so much that the walls actually touch each other on expiration. And that can cause wheeze, can cause a lot of cough. And we can see that when we do bronchoscopy on people. The more unusual causes are subglottic stenosis, when there's a narrowing just below the vocal cords, and occasionally an endobronchial lesion can cause maybe a localized wheeze. And the other thing that can cause localized wheeze, which is not on there, is heart failure and pulmonary edema. The shortness of breath could certainly be heart failure, could be pulmonary embolus, as being mentioned, could be maybe interstitial lung disease, could be just obesity, or it could be actually a dysfunctional pattern of breathing. The cough could be rhinitis, could be postnasal drip, could have symptoms of reflux, which was mentioned, could be post-viral. Sleep apnea is actually a relatively common cause of cough. So if you have someone with cough that's overweight and displays symptoms or signs of possible sleep apnea, we need to think about that. Less common things such as eosinophilic bronchitis, where there's eosinophilic infiltration in the lung, can cause cough. Bronchiectasis, which is a like pathological airway dilatation and thickening, and these people get a lot of cough and usually sputum production, and occasionally ACE inhibitors can be the cause for the cough. So vocal cord dysfunction is quite common. It's actually more common in people who have asthma, and sometimes there might be a bit of mild asthma in the background, but vocal cord dysfunction is causing the main symptoms. And what happens is that during inspiration, our vocal cords open, and during expiration, they close just a little bit. If they close excessively during expiration, and sometimes even if they close excessively during inspiration, it can cause a lot of wheeze. And when you listen to the chest, it sounds exactly like asthma. It's very hard to tell the difference. Some of the clues to it, though, are that often people describe difficulty breathing in, where technically asthma is a difficulty breathing out because it's airflow obstruction, lower airways. The wheeze is difficulty breathing out. Sometimes people say it's worse when talking, and for some reason it seems to be worse while talking on the phone. It tends to have a rapid onset and a rapid resolution. So it might be that someone wakes up and they feel perfectly fine. Then during the day, they wheeze so badly that they almost die and have to call an ambulance and can't cope. But then by the evening, they're fine again. That's very typical of vocal cord dysfunction. That's not typical of asthma. If asthma gets that bad, it doesn't improve that quickly. Sometimes it's associated with change in voice, and can certainly be exacerbated by strong smell. So people say, oh, as soon as I smell perfume, I just choke up and can't breathe and cough, and it sounds like vocal cord dysfunction, and they usually always have normal lung function. Dysfunctional breathing is really common, and I've seen this, I think, more recently than I ever have before, and I think it's because of COVID. I think it's because of COVID's caused anxiety, and I think COVID and everyone having to wear a mask has caused people to change their pattern of breathing, and they've developed dysfunctional breathing. And what I mean by this is that the way we should breathe is from the diaphragm. But what happens sometimes when people get breathless, the natural tendency is, instead of breathing from the diaphragm, they breathe from the top of the chest. They sort of pull the air in like this. And it happens to everyone. It happens to sometimes when people are public speaking, they go into this pattern of breathing because they get a bit nervous, and you're sort of, I've probably done it earlier on tonight, breathe like this. And it's a dysfunctional pattern of breathing. You've probably seen people do this, and then they sort of get a bit hyperinflated, like more air is going in, less is coming out. They feel quite like tight in the chest, and it makes them very short of breath. Then as they relax and empty their chest, they start to feel better. This can happen during rest, it can happen on exertion. And the thing to do about it is to encourage people to actually breathe from the diaphragm, like in the picture, lying down, hand on the chest, hand on the top of the abdomen. And as you breathe in, what you want to do is relax across here, push your tummy out. So you breathe in like that, and it actually encourages to breathe from the diaphragm. And I'll get people to do this for 5 or 10 minutes twice a day just to practice it. But then also when they feel breathless, to think about their breathing. Are you breathing like this? And sometimes people, as soon as you go like this, they go, oh, that's me. That's what I do. Yeah, that's it. Yes. It's fantastic. You think, oh, this is great. Exactly what's going on. And it's great because once they start to practice this diaphragmatic breathing, often they feel better very quickly, and it reassures them that they can control their own breathing. And because the problem is that the vicious cycle going the other way is breathlessness causing more breathlessness, causing more anxiety, causing more breathlessness, and causing more dysfunctional breathing, and it's a bit of a vicious cycle. Sleep apnea, I just spoke about, is very common and should be thought about when we have patients with cough. And so what should we do about it? So in terms of tests for asthma, we should do spirometry for everyone. We should occasionally check for eosinophils and IgE, because if they're elevated, it could be a clue towards asthma. Bronchoprovocation can be helpful, which I'm going to talk about, and sometimes we need other tests to exclude differentials. Bronchoprovocation testing is essentially when we do spirometry and then we get someone to breathe in a substance that will bring on asthma if asthma is present. I'm just going to skip over the specifics of that because I know that we are running short of time. But this is this girl's bronchoprovocation test. And so what we've done is we've done the initial spirometry, which was normal. We've found where the FEV1 is and marked that at 0. And then we've given increasing doses of mannitol, and we've repeated the spirometry and looked to see what the FEV1 is. And if the FEV1 drops by 15% from baseline, that's a positive test and means that this person has bronchial hyperresponsiveness and highly suggestive of asthma. But this girl didn't have that, so she probably does not have asthma. So what are we going to do about it? Well, we're going to go over all of these things. And I suspect that she probably has vocal cord dysfunction or some dysfunctional breathing. And I know that we're running a bit over time, but hopefully it's been helpful to stop and answer questions and things. So I appreciate if people have to leave. But this is another case that's quite interesting. This is a patient I saw in 2015, and it's significant because back then we didn't have access to some medications that we do now. And he was a 61-year-old builder. He was a lifelong non-smoker, and he had asthma since childhood. He was on Seretide, and he had good control until 6 months ago when he had a bit of a viral infection, but he also had a significant dust exposure. He never really recovered. He was very short of breath, unable to climb flights of stairs, very wheezy, and had a dry cough, and was extremely limited in what he could do. His lung function showed that he had airflow obstruction because his ratio was 61%. It was quite significant airflow obstruction because his FEV1 was 56% of predicted. There was a significant bronchodilator response consistent with the diagnosis of asthma and suboptimally controlled asthma, but his gas transfer was normal. So it all fits. We did some allergy testing, and that showed that he had no response to dust mite, aspergillus, or pollen. His serum IgE, which was 46, which although is slightly above the normal limit, is not all that high. His eosinophil count, though, was actually quite high. So an eosinophil count of 0.5 is quite high. Bronchoscopy showed a normal upper airway. There was certainly no excessive dynamic airway collapse, and there was no infection contributing to his symptoms. And he had a sleep study that showed no sleep apnea. So it didn't seem like there was something else contributing to why he suddenly had such poor control and why he was so affected by his symptoms. And so what do we do in this situation? So we could change him to Symbicort from Seretide. I think Seretide's a bit old-fashioned, so I think if I like changing people away from Symbicort to Seretide, I think it has more side effects of upper airway side effects and things, so maybe we try something different, but essentially they're similar medications, so you're not going to expect to solve the problem by going from Seretide to Symbicort. You could add Spiriva. Is certainly indicated because he was on maximum inhaled corticosteroids. So adding Spiriva is the right thing to do. And then we're sort of starting to look at, okay, well, what else? We've gone through the process of making sure there's not anything else contributing to this person's poor asthma control. He fits the definition of severe asthma because despite optimal management and nothing else contributing, he still has suboptimal control of his asthma. So this is difficult to control asthma or severe asthma. And so this is when we need to start thinking about add-on therapies, and this is where we might come to Singulair. And so in this situation, adding Singulair would be quite appropriate and a good idea. But in this situation, adding Singulair onto the management will improve asthma control in about 30% of cases. So not everyone's going to get benefit from Singulair. Singulair is also quite expensive. And so if you start someone on Singulair in this situation, what you want to do is make sure you see them again in a month or so and see, has there been a significant improvement? Because if there hasn't, it's probably best to stop it. And then we need to start thinking about prednisolone, and this might be someone you might consider, you might need to have on a dose of maintenance prednisolone.
Barton, I think John suggested Ultibro in the chat. Just to remember that if you've already got someone on a strong LABA and ICS combination, if you want to add an inhaler, you should add just a LAMA, so a single agent LAMA, because you don't want to be overdosing your patients on a long-acting beta agonist. And if you're swapping them to something like Ultibro, then patients with asthma really do need that inhaled corticosteroid inhaler. So to make sure that you're not omitting a drug by adding or changing inhalers.
Yep. Agree. What about prednisolone, 50 milligrams for 3 days? Sheetal, good idea? Bad idea?
Yeah, I mean, I think he sounds like he's got
idea.
an allergic asthma, so I think definitely a good idea to start him on some prednisolone.
Yeah, so you could do 50 milligrams for 3 days and see what sort of response you got, certainly.
Yeah.
And sometimes people in these situations might settle down with some prednisolone, and once you settle it down, they might be better. But he had symptoms going on for quite a long time. And if you're going to go to 50 milligrams, probably don't want to leave it at that high dose for too long. You want to sort of wean it down or see how it goes. Thinking of Trelegy, what about Trelegy?
Yep. You could change them to Trelegy.
Would be a very appropriate thing to put them on as a try. So we go through the process of reassessing, determine if there's coexistent conditions contributing, is there any controllable triggers, and making sure that they're not having a cigarette with their Ventolin, making sure they don't have the asthma cigarettes. I didn't know until recently that there were asthma cigarettes, but I also did know that Kellogg's tried to cause us all to be obese and have diabetes when they invented their breakfast cereal. I didn't know that they also tried to cause us to have lung cancer by inventing asthma cigarettes. So we want to make sure they're not having their asthma cigarettes. They could be pollens, they could be virus, but what are we going to do? And so in this situation is where we have like some other medications. So biologic therapies. The rheumatologists that had these for ages for their diseases have been really successful, and it's really excellent that in the last only a few years we've had these biologic therapies available for asthma, and there are 3 of them that are available at the moment. 2 of them target the eosinophil, and 1 of them target the IgE. And so these patients need to be exactly as this patient is. He needs to have confirmed asthma on optimal treatment. They do, PBS say that they need to be seen by a respiratory physician for at least 6 months, and that's just to make sure they've been worked up appropriately. If it's not 6 months, it can be diagnosed through a multidisciplinary meeting, and we have an asthma multidisciplinary meeting in Monash that Sheila and I both attend, and can present patients there to get quicker access to these medications. They need confirmed spirometry, asthma confirmed. They need to have had exacerbations requiring prednisolone, and they need to have had a significant amount of prednisolone and still demonstrated inability to get good control. And so these are the medications, and the patients will qualify if their eosinophil count is 0.3 or above, or if their serum IgE is 30, and they also demonstrate allergy on their skin prick test or their RAST. And these are them. Fasenra is an anti-IgE, same as Nucala, and Xolair is the medication for the allergic asthma with the high IgE. So this person represented actually after 4 years. After I initially saw him, I didn't see him again for ages. And I think that this is what happens with these patients with asthma, is that they come along to the specialist, and it's so disheartening because we really don't have that much to add, or we didn't have that much to add. And I think that they just go along thinking there's nothing else that can be done. And the good thing now is that there is something else that can be done. So hopefully these patients who are in this situation actually do come back and see us, because these medications are really life-changing for them. So he thankfully represented after 4 years, struggling with still with shortness of breath and wheeze, and he was really seriously impaired with what he could do. He was on prednisolone and still exacerbating. His asthma control questionnaire, which is the questionnaire that you have to do to see how affected they are by their asthma, he scored very highly on, and he had an eosinophil count of 0.5. So I felt that the anti-eosinophil was going to be most appropriate for him. So he was started on Fasenra. And his symptoms actually improved after 2 days. So after 2 days after his first injection of Fasenra, he felt better than he had felt for the last 3 or 4 years. He was able to participate in activities he hasn't done for 6 years. And suddenly we were able to wean his prednisolone off over 3 weeks, and he hasn't been back on it and doesn't need Ventolin anymore. So it's been a massive, massive life changer for this patient, and certainly many other patients in a similar situation get a huge benefit from these medications. And 6 months later, we need to reassess their asthma control, and you can see just by quickly looking at that he's scoring zeros. So symptomatically very well controlled. And the other huge benefit for these patients is that the reduction in the steroid dose. So not needing to take steroids is such a huge advantage because of the terrible side effects. in the long term. So in summary, I think that what we want to try and do is help all these people as much as possible with asthma achieve and maintain optimal quality of life through healthy lungs. All patients with asthma, COPD and respiratory symptoms really do need lung function to help clarify the diagnosis and guide management. And we should think about really common things that occur, such as vocal cord dysfunction, dysfunctional breathing, sleep apnea in these patients, because they could be contributing to their symptoms. And it's important to remember that there are these new asthma treatments. So if someone's asthma control is suboptimal, but despite doing all the right things, then think of referring them on. That's all I had. I just wanted to say that I'm happy to stay. I know we've gone a bit over time, but certainly happy to stay to answer any questions. We're going to do another talk like this on the 19th of May. So if anybody's interested to come, it's going to be an approach to the patient with breathlessness. And I will send out a feedback form. So I really appreciate if people were able to send that back, and I'll ask for other topics. If you have any other topics, we can always change that to something else. And if you know any others or your colleagues or anyone that would like to come along or might be interested, I'd be really appreciative if you're able to forward it on to others.
Thanks very much, Barton. I'm just going to take you back. There's one question which we missed a little bit earlier on, which was, can you have COPD with a large bronchodilator response, or is that what we call overlap syndrome? Lisa said that she has a 70-year-old patient, late 70s, with a new diagnosis of asthma on a history of heavy smoking.
So I mean, in patients with COPD, they can have a significant bronchodilator response. When they do have a significant bronchodilator response, to me, it sort of suggests that there's at least a little bit of an asthma phenotype. They're sort of acting a little bit asthmatic. It suggests that their airways are a bit reactive. And so for simplicity's sake, I tend to say that they've got COPD with a significant bronchodilator response or COPD with an asthma component. And if that was the case, I would think that they probably do benefit from some inhaled steroid, or if they're unwell enough, with some prednisolone. So that's how I would sort of approach that. And then probably after using the inhaled steroid, repeat the spirometry and see if the bronchodilator response goes away or the lung function improves.
But Ron has just said he sees someone with asthma, treats them with inhaled steroids, and they get better by the time they get the respiratory function test. So won't it be pretty much normal?
So once you see them initially and clinically, they acting like asthma and they've got the wheeze, and you start the inhaled steroid and then send them for the test. Yeah, that's a good point. And I sometimes do think about that too. And sometimes I guess it's a bit easier when we have such good access to lung function testing. We can get patients in. So I usually like them to have their lung function before they start their treatment, because clarifying the diagnosis early is really beneficial. I think, as you suggested earlier, if there is wheeze and it's all fitting, then sure, you could probably get treatment underway. If you're not sure and they're not too sick, then there's probably no harm in waiting for the lung function, because the benefit of having the lung function off treatment and seeing that there's an abnormality, it helps guide treatment. Because if their lung function is normal, then you have to think, oh, okay, well, did they have asthma, or how long do I keep going with the inhaled steroid? Sometimes if there's clinical signs and they improve, then that's probably enough to go on. And if their lung function normalizes, then that's great. The other thing you could do in that situation is say, okay, well, maybe a few months down the track, given that the symptoms are only mild, we're not going to lose anything by stopping the inhaled steroid. I think it's always worthwhile stopping medication. I think stopping medication is a great thing to do. And if anybody's on medication they don't need, then if we can stop it, that's worthwhile. And if someone hasn't had a bad exacerbation of their asthma, it's probably quite safe to stop their inhaled steroid. So just stop it and see what happens. If their symptoms get worse again, do lung function, they might have to go back on it. So I think just trying to get people on the lowest dose of medication is worthwhile.
Lisa has just also said, so all COPD must have a reduced DLCO?
It's a good question. No, not necessarily, because COPD essentially stands for chronic obstructive pulmonary disease. So they do all need to have airflow obstruction, because if there's not airflow obstruction, by definition, they don't have COPD. And as we know, COPD is made up of the two main entities being emphysema and chronic bronchitis. And emphysema is a parenchymal disease, so there will be a reduction in gas transfer if there's emphysema. But if they're predominantly a chronic bronchitis patient, chronic bronchitis is an airways disease, and so they may have airways disease and a normal gas transfer and still have COPD. So it's sort of, COPD is sort of like this overarching sort of diagnosis that we use that is helpful, but everybody with COPD sort of acts differently. The case that I presented where there was airflow obstruction and bronchodilator response and a reduced gas transfer and there'd been a smoker, the reduced gas transfer is really helpful because it tells me that there's parenchymal disease. It says that at least there is definitely a component of emphysema or smoking-related lung disease as well. And I think a nice way to sort of think about all of this is, rather than always just lumping people into diagnoses, just sort of really trying to treat their symptoms. And so a patient with COPD who has mild airflow obstruction, is not really breathless, probably doesn't need treatment at all, as long as they stop smoking. If they've got significant airflow obstruction, they probably do need bronchodilation. If their main symptoms cough and sputum, they probably need respiratory physio and help with sputum clearance and treatment of infection. They may not need bronchodilators. So just trying to think about how that patient is really helpful to sort of guiding what treatment you use for them.
Thanks very much, Barton. I will invite anyone. We're just getting really close to the end. I think we've gone through most of the questions there. So if you have any last minute questions, please feel free to put them in the chat. Other than that, we will stick around for a few moments. So if you want to stay and ask anything in particular, please do. Otherwise, a really big thanks from all of us at London Sleep for coming tonight. I hope you found it helpful, and hopefully we look forward to seeing you again at our next event in May. But thank you very much and have a great night.